Guys, welcome back to Medical Coding with Blue. Today's episode is all about advice for diagnosis code selections. If you are brand new to my channel, welcome. I am Blue. I'm a medical coder. Okay, guys. So, disclaimer first, this is not to replace any official coding guidance, okay? This is just advice. This is for entertainment purposes only, okay? This video is entertainment purposes only. Always follow the official ICD-10-CM coding guidelines for coding and reporting, and always follow your facility's rules, okay? But I want to bring something to you guys' attention today. In section 4 of the coding guidelines, where it says diagnostic coding and reporting guidelines for outpatient services, in section J, right, it says code all documented conditions that coexist. Code all documented conditions that coexist at the time of the encounter/visit and that require or affect patient care, treatment, or management. Do not code conditions that were previously treated or no longer exist. However, history codes, category Z80 to Z87, may be used as secondary codes if the historical condition or family history has an impact on current care or influences treatment. So, in this case, what it is saying is, what did the patient come in with, and any other conditions that they have, if the provider if it's going to impact their ability to care for this patient, that's what you're going to pick up. Sometimes providers will document a patient's, all the patient's chronic conditions. They're coming in for one thing, like a fractured elbow, and they're coming in and they say all these conditions that the patient has. Maybe the patient has diabetes and they have hyperlipidemia, right? Patient comes in and they fractured their elbow. They need to go and take them in for surgery, right? And to repair the elbow. So what happens is, patient is a 55-year-old male who fell and who broke his elbow. We need to take them in for surgery, and they're there and they're coming in for treatment, and they say, okay, we're going to do surgery on this patient. Patient also has hyperlipidemia and diabetes. The labs were reviewed for the patient's blood sugar levels. Blood sugar levels are stable, and so we can go ahead and proceed with the surgery, okay? And in this case, if it was a fractured elbow, we were going to go ahead and pick up the fractured elbow. We're going to pick up how it happened, obviously. But of the hyperlipidemia and the diabetes, what will we pick up? We would pick up the diabetes because the diabetes had a direct impact on the provider's ability to care for the patient. They didn't mention anything about the hyperlipidemia, and it didn't have any impact or cause anything else, any other tests to be run. It was just a simple statement of, hey, he has this. But the provider is not stating that condition had any kind of impact. And it doesn't have to necessarily state this condition has an impact on my ability to care for this patient. No, but they do need to show in the fact that they did say, well, we reviewed the patient's blood sugar levels and the blood sugar levels were fine. Why? Because obviously, if the patient's blood sugar was out of control, this wouldn't be a good thing to take them up to an operating room and have other problems, okay? Because there's a lot of stress on the person, right? So in that case, it's pretty well clear, right? And what about if they were taking long-term use insulin? Absolutely, you would pick that up. And now there's different codes because there's different ones for the different types, okay? Different types of meds for that. So just make sure that you're really looking in the Z codes in the back so that you fully understand. I talked about this a few days ago. One of the best ways to understand the Z codes, the Z code hacks that y'all like to have so much, is to actually look at all the codes that are available. And if you have a really fantastic book like the ICD-10-CM Expert for Physicians that I always recommend, right? And sometimes you say, well, Blue, I got the AAPC book. Well, you can look because the AAPC book has the Z codes in there too, okay? But what I like about Optum is that there's always examples and coding tips throughout their books as well. So that's why I would recommend that. And you take a look back there to see what else is back there. But the thing that I want you guys to take from this video today is when you're looking at this documentation, you're going to see what did they come in for. You obviously know you're going to pick that up. You obviously know that you're going to pick up anything else that impacts that patient's care. If the doctor does not document that something else impacted that patient's care, there's nothing for us to do with it, right? Because that could just be, well, that's just good record keeping. He just documented, or she just documented everything that the patient has. Because you never know if something else might come up later, and did we already know this patient had this condition? That kind of thing, okay? But when we are picking up codes, we are picking up what is affecting that patient and what is causing us to have to spend a little bit more time with this patient, okay? That's what we're doing. So every diagnosis code that you see, every history code you see, you're not always going to have to pick it up. A good coder will know by reading the coding guidelines what should be picked up, okay? We also know that when we see a problem list, right? We always see the problem list. Well, you're not going to pick up all the diagnosis codes in the problem list, because what happens with the problem list, and there is, I believe, a coding clinic about that, but there is things, there's articles about not picking up straight from the problem list, okay? If you're picking up from the problem list and it's not supported in the note, you're in the wrong, okay? That's the thing, because problem lists are often just sort of like a dumping ground for diagnoses that the patients have come in with prior. So we don't know if that's history. We don't know if they still have it. We don't know if it was just an acute condition or if it was a chronic thing. So that's not where we pick up our codes from. We're looking at the history of present illness. We're looking at the assessment and plan. We are looking at those two key areas because that is what is going to tell us what's going on in this story. Now, physical exam, you know you're not supposed to be pulling anything out of that physical exam, right? Physical exam is just the description of what's going on, okay? Yes, we can use the whole document, but the thing is, hopefully your provider is documenting either in the HPI or in the assessment and plan what is actually happening and being very specific. If your provider is not being specific about how other conditions affect their care for this patient, that's something that they may not know. Because when I first started in ortho, I had been in ortho already for a couple of years, and then they moved us into this big brand new beautiful hospital because they built us a new hospital, right? And so leadership in this hospital has said, hey, it is important for the coders to be embedded in these clinics because we need to have strong relationships between the providers and the coders so that we can get really good documentation. We can get excellent results from, the information that we get to harvest, right, from our facility. So they put us in there. Well, a lot of the providers weren't sure that, I document that I looked at the patient's blood sugars for their diabetes, but I didn't know I was supposed to pick that up. Well, that's my job as a coder, to make sure that that they're documenting like they're supposed to, and that I'm selecting the codes like that are supposed to be picked up. It's great if the provider does it, but it is still my job, because that's their job as providers and physicians, is to take care of the patient. I'm there as the coder to make sure that the health information is there. So when I did an example for them and I said, okay, here's the note, and these are all the codes I picked up, and these were all the procedures and everything else, the E&M level if it was applying or whatever. And they were like, well, we didn't know that you picked up the diabetes, but I don't treat that. That was their first thing, was, no, you shouldn't be picking that up. I don't treat that. No, I just used it just to because they have it, and I need to know, if I can give them this treatment or not. And I said, okay, but it impacted your ability to care for this patient. Me picking up the diagnosis code has nothing to do with the fact of whether you are their primary care provider and treating them. And I told them, no one is accusing you of being their primary care provider, only because they're surgeons and I can joke with them like that. But here's the thing, okay? yes, they are not the person's primary care provider when it comes to a condition like diabetes. But what happens is when they have to think about that, then it is necessary to pick that up, because these conditions, like anything having to do with fractures, anything having to do with any kind of injuries, it's going to affect the whole body. Well, diabetes also affects the whole body. It affects how fast a patient can heal, particularly if their blood sugars are well controlled versus being uncontrolled. And if it's uncontrolled, then we know, hey, this provider knows I can't be putting this patient under all this stress. I need to wait until their blood sugar's under control before I can take them to a surgery, for example. So that's why this is important. This is just data that they are reporting, and that we are converting into codes, so that way that they know. We know at our facility, right? This is just an example, that there's a lot of people who have these chronic conditions, okay? And they also have these injuries, or they also have these other conditions, like maybe they have migraines or whatever. And so those are things that when we get this information, because we're selecting the codes appropriately, and these conditions are affecting a provider's ability to care for this patient, then again, we can see things a lot, just all the good things that can come out of this information, like healthcare programs or preventative programs or education for patients in the community. I get very excited because it's true, all of these things, but we don't know unless we educate, okay? And so if your provider is having a patient who has chronic conditions and they're scared and they say, well, no, I don't want it to look like I'm selecting all of these codes. No, that's why your documentation is there, okay? Your documentation is clearly saying, I'm not this patient's primary care provider. I'm the one who is considering this condition because it does impact my ability to care for this patient. And so that's the thing, when you're selecting codes and you're looking at those things, when you're having to do any kind of education, and if you don't do education for your provider, somebody else does it, please save your comment, okay? I'm talking to those who this does impact, okay? Because there's a lot of people that still don't understand what we do. And so the coders are just like, oh, just code. But if you don't know, and if they don't know, then who is telling them? Because you don't know what you don't know when it comes to what can we say to providers. We want to make sure that they're documenting everything that impacts their ability to care for this patient. We don't rely on the problem list to code from, because we don't know if those conditions are still current. We don't know if those conditions even impacted the provider's ability to care for this patient, or if they even had to consider those conditions, okay? And it's the same thing if a patient's coming into a family care practice, right? And they're coming in because they have bronchitis, but on their history list, right, all the things that they've had before, they say pneumonia. Well, there's no need for us to query because that's a history of, okay? That's history and it has nothing to do with their bronchitis, okay? And so that's the thing that we're having to look at. And that's how you start to understand those nuances in what we pick up versus what we don't pick up. Now, if they came in and they have bronchitis and they have a family history of heart disease, do you think that we need to pick that up? No. We don't need to pick up the family history of heart disease because why? That has nothing to do with bronchitis. Now, unless that provider said, well, you know what, you have this bronchitis, but you have a family history of heart disease, and I want to send you to get this test or whatever because you're high risk for heart disease, then yes, you would pick up the family history, right, of heart disease or cardiovascular disease, rather. But again, if they're just coming in for the bronchitis and the provider is not doing anything with that, they just happen to document that they are they have a family history of cardiovascular disease, again, that has nothing to do with why they're there, okay? So we want to look at those things that will impact the patient's care and things like that. COPD, patient comes in, has COPD, but they also have a history of tobacco use, right? They smoked many years ago and they have a history of tobacco use. Yes, you would pick that up, because even though they have a history of tobacco use, if you look in the tabular section, it does give you that code use additional code for, and it'll say if the patient has COPD, if they have a history of tobacco use, you're going to pick that up. Or if they still use, hopefully they don't still use tobacco while they have COPD, you would still pick that up too, okay? So that's when you look, and you're looking in the social history, because social history, it'll tell you the patient is 1 pack per day, right? Smoker, or whatever the case may be. And then you would pick up the F series code for that, okay? So there's a lot of things that you can learn just by when you're starting to code, okay? And when you look things up in the index and then you go back to the tabular, you find the code, look to see at the beginning of the chapter too if there's anything else that you should be looking for in the documentation, such as with the COPD and a history of tobacco use or current tobacco use, okay? If you say, well, Blue, no, I use an encoder at my facility. Well, that's okay. That's all fine and well too. But for my new people, this is what I want y'all to do. Even though you are using an encoder and you have a few minutes, take the time to look up that code in your book just to make sure that there's nothing else you need to add. Now, I understand that it's a time-sensitive thing and everything's about productivity and stuff. I understand that. But if there's additional codes that you still don't know about, that you didn't even think to do that, you didn't even think to pick that up, this is what's going to save your keister, okay? This is what is going to save you from, oh, you didn't pick this up, or oh, you didn't pick that up, okay? So it's about looking at the whole document, avoiding those places where we don't get diagnosis codes from, such as the problem list, right? We do not get them from the problem list. We get them based on what the provider documented, okay? And it's okay to talk to your providers about, like, okay, what's going on when you're seeing these patients. It's okay to do that, because oftentimes they want that counsel, they just don't know it sometimes. And sometimes you don't know what you don't know. And so they would say, well, I didn't know that. Or such and such at a conference told me this. It drives me nuts when some of my providers in the past, when they have done that, I heard this at a conference, and they get so excited about it. No. We are not doing that, okay? Because what goes on at another facility does not mean that that's going to go on here. That's number one. Number two, I don't know their coder, that other provider's coder, and I don't know what their capabilities are, and I don't know if they're just doing like what they're being told, if there's no critical thinking into that, or if there was, or maybe it's just an insurance specific thing. That's those things, all those factors come into play. So because of that, I have always told my providers, as soon as I meet them, whenever they get there to the facility, I tell them to. And yes, I'm going to get back on topic, but give me a minute. I do tell my providers, and this is something you can tell your providers too when you first meet them. If there's something else that you hear from an outside source, or maybe a friend is telling you, or you hear it from, somebody else here in the hospital, please come and ask me about it before you change anything in your documentation, because you, as the coder, have a responsibility to make sure that they are documenting everything appropriately. Obviously not writing everything and doing note bloat, not that. Anything that is going to impact their ability to care for this patient, that is what's going to be the driver, okay? That is what is going to be your focus to help them to get right on their documentation. I've had many providers who have left me a heck of a lot better than when they came to me, okay? Because again, they don't know this stuff, and it's up to us. And again, going through here and knowing, okay, well, if the patient has an additional condition that is going to impact the provider's ability to care for this patient, I need to have them make sure that they are documenting this, okay? You're not looking for extra things. You are completing the puzzle. You are, because they're seeing it, but if they're not documenting it, it didn't happen, okay? So that's one of those things. When you look at like their long-term use medications too, that can also impact their abilities to be able to send a patient to surgery, or to send them wherever, or even to prescribe them something else. So if you see anticoagulants, in there that they're currently on that, because they do the medication reconciliation, right? And you see that in the documentation. And so when you see something like that, and they don't say anything else, but they say, well, the patient is on long-term use, Eliquis, whatever. And they say, okay, patient can continue for now. What are they on that for? Okay. And so because that is impacting their ability to care for the patient, okay, because blood thinners are serious business, okay? And it can make a provider have to change their course of treatment. And again, it's something that we need to know, and especially if they're documenting it. If they're documenting it, it happened. And we need to make sure that we get the full picture out of it, okay? So looking at the assessment and plan, looking at the history of present illness, those are the two key places where we're going to see that documentation and know what we need to pick up. The specificity, though, can come from an X-ray for orthopedics, okay? This is an orthopedic specific thing. Not every specialty is like this. There is a coding clinic about that, though, just so you guys know that if the doctor doesn't really specify, maybe it's an intra-articular fracture and the provider didn't document it, but it was documented, and they did their, say for instance, they did their, their interpretation, and the provider interpreted as intra-articular fracture, right? But when they went to their assessment and plan, they just put fracture. They forgot the intra-articular. Well, it's more specified as intra-articular in their radiology read, right? So then you could pick that up, okay? Pick up the more specific code. So that way it comes out right. And there is, like I said, there is a coding clinic on that, so you can look that up yourself. But it is out there that you can use the X-ray that has a more specific area of the fracture, okay, that can be identified. A more detailed code can be picked up. So that's what you get when you look and you read, okay? And those things are very, very important. And it's important for anybody working, whether you're working in orthopedics, whether you are working in the ER, I was going to say in the X-ray, in the ER, in the ER or in family practice or in urgent care, any of those places, you need to know that. You need to know that, okay? And always come with your resources. So that way, okay, this is official. This isn't just what, we love to code.com said, but just so you know that. But yes, there's a lot of really good things in here about the conditions that coexist and coding of signs and symptoms versus a definitive diagnosis. Obviously, if we know that this is a sign or symptom, and the signs and symptoms, they're going to be those R codes, right? Most of the time, they're going to be those R codes. And so if we know that there's a specified diagnosis versus those R codes, and the provider says, okay, well, the patient came in with fever and cough, right? And turns out they have bronchitis. Are we still going to pick up the fever and the cough? No. Not unless the provider says that, hey, this cough is not related to this bronchitis. It has to do with the cardiovascular. Maybe they're having a heart issue, okay? And they think maybe, something else is going on. But that provider has to make that distinction that these are two separate things. We know, as just in basic pathophysiology, and that symptoms of bronchitis would be fever, would be cough, okay? So those are signs and symptoms, okay? And again, if you're not really sure and you start to pick up these codes and they start with an R, we know that signs and symptoms, and we see a definitive diagnosis, okay, we can look up. You can go to the Merck manual, right? Merck manual, you can buy that used. It doesn't have to be a specific kind. Merck manual is fantastic. The Merck manual, if you don't know, is a book that it gives all of these diagnoses. It gives what they usually treat them with, how they treat that condition, what are the signs and symptoms. So that's going to help you to know what the signs and symptoms are, okay? And again, don't let this overwhelm you. I want you guys to be prepared. I want you guys to know where to find your resources. It's not an excuse to say, well, I'm new and I don't know. No, absolutely not. It is not an excuse. You have to try to catch up, okay? I know it's overwhelming. I know it is. But trust me, trust and believe. If you do what I'm telling you to do, get your resources, the Merck manual, okay? You can even go online. What are the symptoms of bronchitis? And you'll see a bunch of stuff come up too. And that will help you to know, okay, we know that this is a sign or symptom of this. And so that's a really good way. But the Merck manual is going to tell you what the signs and symptoms are, what the treatment is, what the prognosis of this condition is, all the things about it. So that way it can kind of help you, all right? But there's more direction in here about signs and symptoms versus a definitive diagnosis. And again, if they say the signs and symptoms, and then they say in the outpatient setting, and they say that this is probable bronchitis, right? Okay, so if they say they have cough and a fever, and they say that the patient has probable bronchitis, well, we know as outpatient coders, once we see anything ambiguous, probable, we don't know for sure if it's bronchitis or not. So in this situation, we would code for the cough and we would code for the fever because the provider says it's probable that it is bronchitis, or it is suspected that it is bronchitis. Again, we wouldn't pick that up because those kinds of words automatically negate that condition, and we have to code for the symptoms. So that's when we can say, okay, well, they didn't positively tie it to this because they're not even sure if they even have bronchitis. That's how you know. And how do we know? That's how we know. Because it's all here. It talks about that. Probable, suspected, likely, maybe, could be, possibly. And I tell my providers to do that too, about that too. I tell them, when you're documenting, it is consistent with probable. I said that just completely changes everything. Well, but it's probably that. And I was like, okay, but again, if you're saying it's probable, that's not definitive. We need either it is or it isn't. You don't have to dress it up with all these other words. If it is, then you don't put probable. If it is not, or you don't know, or you're not sure, then yes, you can say probable. But the second you say probable, I have to go with symptoms. Anything that is probable, suspected, likely, maybe, consistent with, these are all words that are ambiguous and that are going to just negate that, us being able to pick that up until you know for sure what it is, okay? And sometimes that's the case. Sometimes they don't know what it is right away, okay? That's why we code for signs and symptoms, okay? Just saying. So, have I given y'all enough to think about yet? That's why the guidelines are so very freaking important. Very freaking important. Because, again, that's how you know what to pick up and what not to pick up, okay? And anything that's suspicious as far as, like, if it is a symptom and you're not sure if it's related to a definitive diagnosis, always go to Google. Always go to your Merck manual and look it up just to see, is this a symptom of this? Because it'll tell you right away, okay? Don't begin into no chat GPT on those though. I'm gonna say this and I'm gonna wrap it up. You know, if y'all think playing with this, oh, it's such no, it is helpful, it's a fun thing. Let me tell you something. Chat GPT is only as smart as the articles that it's bringing up. It doesn't have the ability to critical think. It will quote from articles based on your question. And these articles may not even be written by somebody that is an authoritarian, as far as like they have the authority, they have the education, and they have the knowledge to be able to say these things. People can say anything and ChatGPT will pick it up. And so doing any of this AI fooling around with this is it's just stupid, and it's a waste of time. I seen this post earlier on LinkedIn where a doctor had asked one of these, it wasn't ChatGPT, it was the other one, and it was asking it to put up an image of the rotator cuff, and it didn't. It did something else completely, and it was showing like the clavicle. It was showing it as the supraspinatus. Really? It's a clavicle is a bone and versus the whatever. So again, you cannot trust the things that you get from ChatGPT or any of these other stupid AI engines. Okay, you cannot trust this, and to put your education into the hands of who knows what is just ridiculous. Don't do it. Don't do it. Okay, the book is always going to be the way to go. With that said, I'm going to go ahead and wrap this one up. Thank you guys so much for joining me. If this video helped you, please like, subscribe, and share, and I'll see y'all next time. Bye.